Hey everyone, this is Gina Herrera, and I'm going to be giving the lecture today on maternal assessment. You may hear me refer to it as prenatal assessment or antepartal assessment. Okay, but we're going to go through the assessment, and it's just like the assessment that you've been doing on your patients. The only difference is that we are assessing the pregnant woman. All right. Let's start off with some diagnosis of pregnancy terminology. We're going to talk about three categories of signs of pregnancy. The first one is presumptive signs, and these are the least reliable as far as relating to pregnancy. These are just, again, nothing written in stone. It could be related to something else other than pregnancy, and they're called presumptive signs. The first one, amenorrhea. That's when the patient misses her cycle, and the first thing she's thinking is, maybe I'm pregnant. So she, usually does the home pregnancy test. But what does amenorrhea mean as far as it could be something else? Well, it could be issues with the patient. Her hormones could be out of whack. So she may not get her cycles on time, and they may not be regular. Also, our athletic patients usually have issues with their cycles being regular because they have so little fat tissue that they have pretty much, sometimes they skip their cycles for months. So again, amenorrhea is just a presumptive sign. It's nothing that is solely related just to being pregnant. Nausea and vomiting. Well, nausea and vomiting, usually that comes at first trimester, the first part of the pregnancy, where the patient usually feels nausea or they actually have some vomiting. It could be related to the pregnancy hormone that we're going to talk about later in this lecture. But it doesn't solely just pertain to pregnancy, because we all know that nausea and vomiting could be related to anything. It could be a virus. It could be something that the patient ate. Or it could be something, other than that, relating to upset stomach or a flu. So nausea and vomiting is just presumptive. Excessive fatigue. The patients that, become pregnant usually experience excessive fatigue, especially in that first trimester, because the baby is taking a lot of energy and a lot of nutrients and everything that you have, and it pulls away from the patient. So the patient can experience some fatigue. They can, feel like they have to have a nap. They're just always tired, especially in that first trimester. But when are you never excessively fatigued under other circumstances? I know as students you're probably excessively fatigued starting classes and getting stressed and trying to get through the semester. So again, excessive fatigue is just a presumptive sign. It's nothing solely related to pregnancy. Urinary frequency. Urinary frequency could be related to something other than pregnancy. It is common in pregnancy, especially within that first and third trimester when that baby seems to be on the bladder. There's a lot of pressure on the bladder, but it could also be related to something as simple as a UTI. So it's not something, again, that is solely related to pregnancy. It's just presumptive sign. Breast changes. The breasts do change with pregnancy. They become more vascular. You can see the vessels more. The nipples darken and things change. But breast changes could also be related to just even monthly cycles coming, or just hormonal issues where the breasts are very sensitive and they're very, very tender and sore. So again, it's just a presumptive sign. Quickening is usually refers to movement of the fetus in utero. And just so you know, we do have, with pregnancy, 3 trimesters. So it usually goes from 1 to 40 weeks gestation, or even a little bit over the 40 weeks, usually no longer than 42 weeks. But it's broken up into three sections, and they're called trimesters because there are three sections. The first one is from week 1 through 13, and then the second one is 14 through 26, and then the remainder is the last weeks from 27 to all the way to 40. Okay, so when we talk about weeks gestation and in the pregnancy, that's what we're referring to. The weeks gestation from 1 to 40 weeks, or even a little over 40 weeks, again, like maybe 41, 42 weeks. We talking about development? Are we talking referring to the patient with weeks gestation? That is how we express it. So quickening is fetal movement, and usually it's felt between the 18th to 20th week gestation for a prima gravida. So a first time being pregnant mom usually feels quickening, between the 18th and the 20th week. 16 weeks for a multigravida, previously been pregnant. And again, this is just presumptive because quickening, may not be felt the same way. It may not feel like the baby moving. I know a patient of mine had said, I had no idea I was pregnant. I just thought I had a lot of gas pain, But again, it's just presumptive. I know it sounds like it should be more than just presumptive, but that's what the book refers to as presumptive. So why between 18 and 20 weeks for a first-time mom compared to a multigravida, one that's already had pregnancy in the past, feeling it earlier? Well, it's because the first-time patient doesn't realize what is going on or what they're feeling, so they don't really pick up on it till later in the weeks gestation. Whereas the second pregnancy, or the patient that has been pregnant already and has had other pregnancies, knows what it feels like and realizes that it is related to fetal movement, and they're feeling their baby move earlier at the 16th week gestation. But quickening is still just presumptive. It is not anything, solely related to just pregnancy. The second category are probable signs. So they're not definite, but they're not presumptive. So they're a little bit more reliable than presumptive, but still, again, nothing solely related to pregnancy. And you're going to find that these are more or less things that are encountered by the healthcare practitioner. The first one, abdominal enlargement. Well, abdominal enlargement, of course, with the growing fetus, the abdomen does enlarge. The uterus is the house of the baby, and as the baby grows, so does the uterus. It expands and it gets heavier because it gets more volume, and there's a lot of changes with the abdominal area, so it tends to get enlarged. But then again, that could be related to fibroid tumors. It could be related to any kind of abnormal growths in the abdomen. It's not solely related to pregnancy. It is just a probable sign. Goodell sign is softening of the cervix. Again, this is something that the practitioner will feel. When they go in to do a vaginal exam with a sterile speculum, they'll go in and, they can look at the cervix, but this, usually when we say Goodell sign, is felt. So they're going in doing a digital exam, not so much a visual exam, but they go in and they can feel the cervix. And what happens is it's usually firm in nature, but it starts to soften and loosen and get more, friable. So with Goodell sign, again, that's a probable sign of pregnancy, something that is experienced with the practitioner exam. Chadwick sign is something that would be visually seen, and that is when they go in again with a speculum and they look inside and they view the cervix, and the cervix has a bluish color or a bluish hue. And what that is, it's related to hormones that cause the pooling of blood to that tissue where things are changing. So it takes on that bluish color. And again, that's something that the practitioner will see on exam. Hager sign is a softening of the isthmus of the uterus. So when the practitioner puts those fingers inside to feel inside, they will put another hand or the other hand on top of the abdomen, and it's so soft that they can actually flex, or they can feel the cervix soften with the isthmus of the uterus. It all kind of is together. So that again is something that the practitioner will do upon exam. It's called Hager's sign. So it's a softening of the isthmus or the neck of the uterus that they're feeling. So that is also a probable sign. McDonald's sign is another sign I'm not going to hold you responsible for, but it is an ease in the flexing of the body of the uterus against the cervix, and that's just the movement of it flexing up with the uterus and the cervix. But like I said, I'm not going to hold you to that one, but that is a sign that's also considered a probable sign for pregnancy. So these are more or less found by the practitioner. But as you can see, I don't know why my practitioner's hand is not gloved, but they're going in doing an exam, and that bluish little area right there is the cervix, and that is what they're feeling softening, and they can see it. You can see it's blue. So that's where those changes come in, and those are probable signs. Some other probable signs: Hager's sign we just talked about, but a positive pregnancy test. Positive pregnancy test is just probable because we can have false positive or negative results. Sometimes they may not pick up on the hormone that's usually excreted by the body through the urine with those pregnancy tests. They're not as reliable as, they're getting more reliable, but at some point in time they can still have false positives or even false negatives. So a positive pregnancy test is not anything definite, but it is a probable sign. Braxton Hicks contractions. Well, the uterus is a big muscle. And just like the muscles in your body, in your legs, in your arms, sometimes they contract. Sometimes it contracts. So it could be related to pregnancy, because as the uterus grows and the fetus grows inside and those muscles get tension put on them in that uterine area, they tend to have some contractions, just like our bodies do with other muscles. But they're not solely related to pregnancy. But again, they call them Braxton Hicks. And by any means, you'll hear me talk about it later. They're not labor pains or contractions. They are just contractions of the uterus. And again, it's just from the weight of the fetus and just strain on the uterus with other things going on inside. So it's just a probable sign. Then we have ballottement. Think of a balloon bouncing up and down. Okay, how it's just floating in the air and it bounces on the tip of your fingers if you're tossing it up and down in the air. Well, the cervix will do that to the practitioner when they go in to do the exam. Sometimes they can feel the cervix bouncing up and down, and you can see my diagram here where it's called internal ballottement. Usually this is going on around 18 weeks where they can feel that. But it's just a probable sign. It's, again, nothing that is solely related to pregnancy. These are the most reliable. They're called the positive signs of pregnancy. And the first one is fetal visualization. So you cannot attribute this to anything but pregnancy, seeing that fetus. How do we see that fetus? Believe it or not, you can see the fetus on an x-ray, but of course it's contraindicated to x-ray a pregnant patient. They can have some issues from the x-rays affecting the development of the fetus. So we don't, of course, do that, but we use an ultrasound, whereas we can put the ultrasound through the vagina or over the abdomen with the transducer, depending on how many weeks gestation. We would use the transvaginal earlier in the pregnancy, whereas we could use the transducer in the latter part of the pregnancy to visualize the fetus. We can see the fetus, we can see the movement of the fetus, we can see, the movement of the limbs and such. So fetal visualization can only be attributed to a fetus. Fetal heart sounds. So when you hear that baby's heartbeat, that again can only be attributed to a fetus. As a matter of fact, the fetus's heart rate is normally 110 to 160, and it can only, you can hear it with a Doppler. We're going to talk about that, or a fetoscope. And those are just instruments that we can put up against mom's abdomen. The fetoscope is almost like a stethoscope that goes on the abdomen with ear pieces that you can hear the baby's heartbeat. You may not see that very often anymore. I have seen a fetoscope hanging around the OB units once or twice. But we more or less are going more with the Doppler, and that's similar to the Doppler that we use on our cardiac patients to check pulses. Well, when the baby is developing, of course, very early. Usually it's very, very low around that pubic area that we pick up on the baby's heart rate. It's very fast paced because I said it's normally 110 to 160, and it almost sounds like a little galloping horse. It's like okay? It's fast and it's very, very crisp. We call that phonic souffle, and that is related to the fetal heart sounds. Okay, we have uterine souffle as well, and that is mom's heart rate. It's almost like a sound, like a swish sound, and it's very slow. It's the patient's pulse, and it's picked up over that abdominal artery area. So if you're checking for baby's heart rate and you're scanning over the abdomen, because remember, at the beginning, it's very low in the abdomen on mom with the Doppler. But if you go into the doctor's, like you should through the pregnancy, of course that baby's going to grow and develop. So that heart rate might be in the upper areas and depends on where the baby is, if it's laying breech or if it's side or, where it is. But you may be around that umbilical artery area of that mom, and it may not pick up just the baby, but you might pick up the mama's pulse. So we call that uterine souffle. That's mom's pulse. And again, it's a slower pace. It's almost like it's in the distance. It's not as crisp and fast because it is the patient's pulse. And if you were, you're not sure what you're hearing and you think it could be the baby's pulse being really slow, you always could take a radial pulse at the same time as you keep that Doppler on the abdomen, and you're listening and you can feel the pulse. If it's synchronous, then it's probably mom's pulse. If it's not synchronous, then it could be the baby in a very low heart rate. But usually the heart rate of the newborn is very quick, it's very crisp, it's very fast. And again, 110 to 160 are the normal, is the normal heartbeat range. Palpable fetal movement. Well, we kind of talked about fetal movement with quickening, as the baby moves. But palpable fetal movement, it could be felt by the practitioner or it could be felt by the patient. So, and even sometimes you'll see a footprint kind of go through the side over mom's abdomen. You can even see, an elbow coming through. But, the patient will start feeling it again. Patients that are first time pregnant, usually it occurs later than the patient that's been pregnant before. They're familiar with what they're feeling. So, again, that quickening, I know, it's confusing, but the quickening is here. Palpable fetal movement, with patient having palpable fetal movement that they can actually feel it, is a positive sign. So we talked about pregnancy and weeks gestation. Now there's some things we need to talk about here, some terminology. So gravida stands for the amount of times the patient has been pregnant, no matter what the outcome. So if they have a pregnancy and it lasts 3 or 4 weeks and they lose the pregnancy, that still counts as a pregnancy in their history. Parity is the delivery of some sort after 20 weeks gestation. Okay, so after 20 weeks gestation, if a baby is delivered, whether it's, a live birth or even if it's not a live birth, parity stands for a delivery after 20 weeks. Okay, so take myself for example. I'm a gravida 3. Okay, my parity is 2. I've had 2 babies past 20 weeks gestation. Now, I said I was a gravida 3 parity 2. Okay, so this is where it's going to get a little tricky. So when we talk about parity, that's after 20 weeks, but we don't know really what the outcome was just from knowing it was 2. So we use another method called the TPAL, which is, hold on for 1 second. I'm sorry. Let me go back. Okay, I'm sorry. But the TPAL is a more specific or more descriptive way of talking about what went on with the pregnancy as far as the parity, or if there is, what was actually the outcome. So when we say TPAL, T stands for term, P stands for preterm, A is for abortions or miscarriages. So abortion is a loss, whether it's an elective abortion where mom goes out and physically, does the act of abortion, or she spontaneously loses the baby on its own. Okay. And then living is how many living children. So when we take in a history, we look at the gravida, we look at the parity, but then we want to know specifically what happened. So we think about the TPAL, and that's a more descriptive way of talking about the outcome. Now, some ground rules. What is term? Term is if you carried the baby all the way to the end of the 37th to the 38th week, if they deliver after the end of the 37th, the beginning of the 38th week, that is where term starts all the way till 40, 41 weeks, 42 weeks. Okay? Preterm is the P, and that is anywhere between 20 weeks if the patient delivers, all the way to that cutoff where we say it was term. So 20 weeks to the end of the 37th, beginning of the 38th week. Okay, so that's the preterm area. Okay, abortions or miscarriages. So if there is a loss, the baby dies in utero, and it's prior to 20 weeks, it is considered a miscarriage or abortion. Okay, so anything that happens prior to 20 weeks, of course, the baby's not going to live, at that point. But if the baby is delivered or the baby is, mom throws off the pregnancy, then it is considered an abortion if it happens prior to the 20-week gestation. So another thing you need to think about is after 20 weeks, if the baby dies in utero. So after 20 weeks, all the way through term and beyond, it's considered a stillborn. Big difference, because this baby will have a funeral. This baby will have a burial. Okay? Not that it's not we do genetic testing and such just as we would if it was before 20 weeks. So, it does entail other things. But depending on how many grams the baby is and how far they carry it, that would consider if it's an abortion or if it's a stillborn. But again, after 20 weeks is considered the time that, 20 weeks and beyond, it becomes a stillborn if it delivers. And there is, we call it a demise, which means it's a baby that is no longer alive. Living is the L, and that's how many living children mom has in her past. So just to go through this, so TPAL, term, is anywhere through the pregnancy if they carry it if they carry it at the end of the 37th week, beginning of the 38th week, on to the very end, like 40, 41, 42 weeks. That's term. Preterm is anywhere between 20 weeks and the end of that 37th, beginning of 38th week. Okay. Abortions, or again, miscarriages, or, that would be prior to 20 weeks if there's a loss. And after 20 weeks, it would be a stillborn. And then the living. How many? Now, another tricky thing I'm going to tell you is that when mom is carrying more than one baby, it is considered one pregnancy. Even though there's 2, 3, 4, 5, 6 babies in utero, it's considered one experience or one pregnancy. Okay? Just as the delivery is considered one experience or event. Okay? So if I was pregnant, just say I only had a set of twins, and my twins, I was pregnant with twins, and I delivered my twins, and they were term. Just say they were term. So I'd have one term delivery, 0 preterm delivery, no abortions or miscarriages, and I'd have 2 babies. So the only place that you're going to get credit for more than one baby is under the L, the living, how many babies you have. So again, if it's one pregnancy and one delivery, it is that way, whether it's 1 baby, 2 baby, 3 babies again. So more than one baby, the only place you're going to show more credit or see the credit for more than one baby is under the living. So knowing all these ground rules and having them all kind of mapped out for yourself, let's try this example. All right, so I want you to find out the gravida and the parity and then the T-PAL for this patient. Jane is currently pregnant at 10 weeks. She has a set of twins that were delivered at 34 weeks gestation. She had a miscarriage at 6 weeks gestation, and she had one other delivery at 39 weeks gestation. So how would you record her pregnancy history using the GP and the T-PAL method? Okay? So looking at this, you can jot down your little notes of what went on and what was her history. And you can go ahead and try and work that one out. Let me give you a couple of minutes, and then we're going to go on and I'll show you what it came out to be. Okay. Well, let's see what we got. If you answered G4, P2, and the T-PAL was 1113, that is correct. So to sum it all up, Jane had one term delivery at 39 weeks. She had a set of twins, which count as one pregnancy and one delivery at 34 weeks. She had a miscarriage at 6 weeks and has 3 living children at this time. Okay? So it should be gravida 4. So people say, Ms. Herrera, how do you get gravida 4? Don't forget, guys, let's go back. Jane is currently pregnant at 10 weeks. Don't forget to count. Jane is at the OB, and she's thinking she's been diagnosed as being pregnant. So we're going through her history. So when we say gravida, we're counting the pregnancy that she currently is experiencing as well. So, that would be where your 4th one comes in. 39 weeks is term, 34 weeks is preterm, but again, if it's twins, and even though it's more than one, she gets credit for one pregnancy and one event or one delivery. Miscarriage at 6 weeks, 3 living children under the L. Okay? This is kind of tricky, and you will see it again, I promise you. So you definitely want to get this and figure it out and be able to work it. So if you need extra practice, I have posted on Canvas some questions asking about the G and the P and the T-PAL and how to figure it out. And I also posted the answers so that you can check yourself. If for some reason you're struggling or you're not sure what you're doing here with this, then you definitely want to let me know. Email me and let me know, can we meet or talk to me about it so that you can figure it out, because it's really important that you do understand this. And when you're in clinical, when you're taking your history on your flow sheet for your assessment on your pregnant patient, you're going to have to figure it out on there as well. So you need to know it. Okay? How do we determine the due date? It's called Nagel's rule. So we take the first day of the last menstrual period and subtract 3 months and add 7 days. So for instance, if my first day of my last menses was June 10th, okay? So like at this point I'm in July and I go to the doctor and I figure out I'm pregnant. So the doctor's going to ask me, okay, when was your last period? What was the first day of your last period? Well, it was June 10th. So if I subtract 3 months from that date and add 7 days, my due date should be March 17th. Y'all see that? The due date you might see expressed as EDB, estimated date of birth, EDC, estimated date of confinement, or EDB could be figured out not just by the Nagel's rule, but with this little wheel that I have here up on the screen. We have a little joke. We call it the Wheel of Fortune. So it actually is a little cheap instrument for us to use. We keep it in our pockets sometimes, or we keep it at the nurse's station. When a patient comes up and says they're not sure, but this is when the period was, and they're not really sure when their due date is, or the doctor has been doing ultrasounds, we usually can just estimate, again, if they give us that last cycle, the first day, we can wheel it out by the months on this wheel and come up with the due date. So also, if you get a patient that's really not supposed to be in labor and she says, I am due on, I don't know, say they're due on December 20th. Okay, we can put the due date on this as December 20th, and we can go back and say, okay, we're in the month of August, or we're in the month of January, or whatever it is. We can figure out how many weeks she is based on this wheel with the due date. So it's just a neat little gadget to have. Some physiologic adaptations with pregnancy. So things change. The body changes, the systems change. There's a lot of changes going on. Mom's body has to compensate for another human being. So there's a lot of changes, especially where the baby lives. The baby lives in the uterus. It is the baby's house. So it does tend to increase in length, increase in weight, and increase in blood volume. So there's more blood being circulated to it. And like I said, it is a big muscle. One big thing you do want to know, mom's vena cava can be compressed by that heavy uterus and that baby, especially if it's growing inside and it gets big. We never leave a pregnant woman flat on her back because they can get, their vena cava could get compressed. And when that happens, their blood pressure drops. We call this supine hypotensive syndrome or vena caval syndrome. So even if you tilt that mom a little bit to the right and just put like a little rolled up towel under one hip or the other, just tilting gets that baby off that vena cava and that uterus, that heavy uterus off the vena cava to keep that mom's blood pressure stable. Because what do you think happens when mom gets hypotensive? I can tell you that the baby is not getting the perfusion it's adequately been receiving. The baby's not getting that oxygenated blood, that blood flowing, because that mom's blood pressure is dropped. So we never want to leave our pregnant mamas on their back flat. They can lay on their back, but we want to tilt them from one side to the other with a pillow or with a little like wedge or so, but we never leave them flat on their back. And this is, the baby will tell you, I'm not liking this, because if you have them on the monitor, you're going to see a decrease in their heart rate. Okay, and that's from them not getting the oxygen it needs. Okay, Braxton Hicks contractions, here we go again with those. Those are the most annoying things because, again, they're not real labor contractions. They're just like, I call them, just a tightening and relaxation of the uterus. And it's usually from, again, that uterus weighing so much. And it just causes it to contract because it's irritable from the weight. if they were real contractions, because sometimes they can get like a little real tight, and then they relax again. But if you're confused and you say, well, how do you know if it's real contractions or they Braxton Hicks? Braxton Hicks contractions, if you do anything like exercise, or you walk briskly, or you move a lot, usually Braxton Hicks will go away. Real contractions, the real labor contractions, no matter what you do, they're not going to go away. If anything, they're going to get stronger. So that's something that, you know, you can distinguish them between. How do we measure gestational age? Well, we can measure gestational age using a tape measure. It's really like it's a paper tape measure that the practitioner uses in the clinic. Every office visit, they start to measure the fundal height. Fundal or fundus is another name for uterus. So we call it the fundal height. And we figure out the fundal height, and it's usually measured in centimeters. So we usually go from the top of the uterus, which is right under mom's breastbone, all the way to that pubic bone. And we come up with so many centimeters. The crazy thing is that at some point, you get a patient that's 22 weeks. She comes in for her clinic visit. You do her fundal height, and you get 22 centimeters. It's weird. Sometimes it just correlates, exactly with the week's gestation. Okay? But then after that 36th week, what happens? That baby starts to drop down, right? Getting ready to go down in that birth canal, because it knows in 3-4 weeks we're going to be having a delivery. So it no longer correlates because it's going to be a big difference. The measurements are not going to be the same in centimeters as the gestational age in weeks gestation. So we talk about fundal height, measurements for weeks gestation. There is an illustration in your textbook. You need to go back and look at that very closely. 33.21 is the illustration, and it's on page 2221 in the text. So you want to go back and look that over. As you can see, when the fundal height is 20 weeks, it's at the umbilicus. So again, you got to remember what's going on with the development of weeks gestation and where the fundal height will fall with mom's abdomen. The cervix. Well, we talked about the cervix. Cervix is usually firm, it's thick, it's, usually closed until it's time for the baby to come. It starts to loosen up and even soften, and sometimes, there's some cervical changes toward the end. But we want to make sure it's competent. Well, what does that mean, Ms. Herrera? Competent. It is strong enough to adequately support the products of conception and the baby, the pregnancy itself. So that means we want it to be able to stay closed and stay strong enough to sustain the pregnancy. When it's incompetent, it's starting to dilate early and it's starting to open. And that's where you see these patients will have a loss. They lose the pregnancy because that cervix can't handle or competently function. Okay? Chadwick sign, we talked about that bluish color to the cervix that the practitioner will see. There is a thing called a mucus plug, and it looks like a ball of mucus. So if you blew your nose and you had a ball of mucus in the Kleenex, that's exactly what the mucus plug looks like, and it covers the cervix inside. It just kind of plugs up to protect, again, nature's way to protect the baby. At the end of the pregnancy, the patient will experience a loss. They may go to the bathroom and wipe and see this big old mucus glob. And that's where the patient might say, I lost my mucus plug. So again, toward the end of the pregnancy, when things start to change and it looks like we're getting closer to the end, the patient will lose their mucus plug. Ovaries change because the ovaries have a job in a woman's body. They do different things at different points with progesterone and all kinds of hormones, estrogen and such. So the ovaries will stop producing ova during pregnancy. They stop producing the ova, but will continue to produce the hormones until the 11th week of pregnancy. Progesterone is secreted until about the 7th week of pregnancy, and then the placenta assumes the task. Okay, so you ever hear where a patient might have some spotting or bleeding or something going on at the beginning of the pregnancy? Sometimes they may require progesterone injections to sustain the pregnancy. And again, progesterone is one of those hormones that works up until that 7th week of pregnancy, and then that placenta will assume the task. The vagina. It thickens with pregnancy, becomes more pliable, distensible. Again, it's got to be ready because that's where the baby's going to come through. So it has to, again, it has to make some changes. There's increase in secretions that are more acidic in nature. So again, nature's way of protecting the baby, putting acidic secretions to kill any microorganisms or bacteria that may tend to try and grow and get up in that area to harm the baby. So acidic in nature. They are prone to a yeast infection, which we call candida. Candida is the organism. And the patient may experience yeast infections in pregnancy. It's not anything that's not common. I mean, it happens. The breast will get increase in nodularity, sensitivity, size, and remember I said they even have more vascular veins. You can see the blue veins. The breast almost like a real translucent. You can see all the vessels and everything. Kind of looks like a map of some sort. But it is the breast, and they are growing, and they're preparing to for lactation at some point. The nipples enlarge to become darkened, preparing for lactation. So colostrum, especially at the end where the breasts are really big, I can remember, I had to wear breast pads inside my bra because my breasts were so engorged at the end that I was leaking. And I mean, sometimes it happens. And sometimes it happens when another baby is around and is crying. It's natural that the breasts kind of let down and they may leak some of the breast milk. Some people experience that, some people don't. But that breast milk that leaks, or that first breast milk that comes out even after delivery, is the colostrum. So the colostrum comes out, and that's really not the big breast milk. That's just that first breast milk that comes out. It's the darker yellow or white, real thick milk that comes out. And believe it or not, you know how we talk about Bluebell ice cream has the cream on top? Well, this is the cream on top for the breast milk, okay? So colostrum is very, very rich in nutrients for the baby. It has so many immuno properties to help the baby with their immunity and their immune system. And we know breastfeeding is really great for the baby. It provides them with so much and even prevents them from getting cancers later in life. So the colostrum is part of the breast milk that comes out. It is the first. So if you hear me talk about colostrum, we always tell moms, the mom might say, it's colostrum. I don't think my baby's getting anything, but really the baby is getting lots of nutrients through colostrum. Anyway, that's my breast milk spiel. I'm going to go on. Let's talk about cardiovascular, where the heart rate might be slightly increased. Let me go back. Heart is displaced up and rotated forward, and it is slightly increased, their pulse. And it does that because, again, that growing baby is kind of, I say, rearranging the furniture inside. It's moving things around. So it does displace the heart. Not to the point where it's not normal or it's going to injure the mom, but it does change things around in there. There is an increase in plasma volume. So mom will have an increase in RBCs in the blood, and they may cause her to have physiologic anemia of pregnancy, which leads to a slight decrease in the hematocrit count. Nothing out of the ordinary, or, it doesn't like plummet down, but the hematocrit count might be slightly lower than it normally is. Does it mean that the hematocrit and the hemoglobin levels, well, the hematocrit levels, and then, of course, the hemoglobin levels, are, anemically decreased? Not necessarily. Okay. So because the increase in volume occurs, there's more blood volume, so that the cells become a little bit more diluted. So the cells are there, they're just more diluted. Okay. Um, you might hear it referred to as physiologic anemia, diluted anemia. So, and again, the cells are there, there's just more volume that's, perfusing because of the pregnancy. Um, that it will dilute the blood cells, even the RBCs. So we call it physiologic anemia. It's not true anemia. Now, we do have some patients that are truly anemic, and some of them are anemic before they even get pregnant. But this is, think of you're mixing a pitcher of lemonade. It calls for 2 gallons of water and 2 scoops of the lemonade. But say I add too much water. I add another half a gallon. I'm still going to have the same amount of diluent or powder to make the lemonade, but the water is going to be more than it should, so it's going to taste weaker. But it is truly still the same concentration as far as how much lemonade powder I've added. But that's kind of that's my analogy for trying to explain physiologic anemia. Okay. And then we said the heart rate will increase 10 to 15 beats per minute, a little bit higher than it normally had been, but again, still within the normal range. You will have a little slight decrease in blood pressure, and again, it's nothing that it bottoms out or anything. It's just a slight decrease. It can happen. But you will see an increase in cardiac output. Why? Because we have a lot more volume to circulate through, right? So the increase in cardiac output is there because that extra volume is on board. And people say, well, why do we have extra volume? Well, of course, it's trying to sustain for the pregnancy, but again, nature's way of protecting mom. So if she tends to lose 300 milliliters of blood or even 650 milliliters of blood, she may not need blood, depending on her, if she's anemic or not. But that extra volume is helpful because a lot of times you have some bleeding with deliveries. But it's just they have that extra volume to protect them from hemorrhaging. So it keeps them, stable. Also, there's an increased risk for coagulation and tendency for coagulation. They tend to be very prone to having blood clots because, again, that difference in the blood and the excessive volume and the way things perfuse through, especially in the lower extremities. We know that gets the less perfusion, it gets there slower because of them being distal. So they do have an increased tendency for coagulation to occur. And then the risk of venous thrombosis is there. The respiratory system. Well, there's an increase in oxygen requirements, and I know, especially before that baby drops down at the end of the pregnancy, getting ready to get in position for the delivery. Sometimes mom is carrying that baby so high, she say, I feel like it's in my chest. And again, it does. It feels like it's way up there and it's compressing the diaphragm. So they do tend to complain of shortness of breath. They do have some changes in breathing patterns. They get more abdominal to thoracic. They go from abdominal to thoracic breathing pattern or breathing changes. Increased vascularization of the upper respiratory tract, so they tend to have some nasal stuffiness and epistaxis. Think of it this way, all those membranes are all engorged and swollen, okay? So they can feel that stuffiness. It almost feels like they're always kind of stuffed up with sinuses. And epistaxis, well, from all that swelling and that stuffiness, sometimes those little vessels can rupture and cause a nosebleed. So that's not, again, out of the ordinary. Does everybody experience this? Maybe not. It is just one of those things that has been found to occur with the respiratory system with pregnancy. The renal system, there's a 50% increase in glomerular filtration rate, okay? there is a decrease in renal threshold for glucose. So if there's a decrease in that threshold for glucose, you think that glucose is spilling over? It sure is, right? And then add some decreased smooth muscle tone to that, and you got yourself a recipe. I'll tell you what. Urinary frequency again during the first and third trimesters, and that's from that enlarged uterus and that growing fetus. But you got yourself a recipe for an increase in UTIs, okay? Because that glucose is spilling over with that decrease in renal threshold. There's 50% increase in glomerular filtration rate and that decrease in smooth muscle tone. So they are always prone to have a UTI. In fact, a lot of time the UTI is what can cause them to go into premature labor. So a lot of time if patients come in and they're in early labor, then they shouldn't be, delivering anytime soon. We usually do a sterile catheter specimen of the urine, and we rule out a UTI because, again, it's very, very common in pregnancy, and it can be the culprit for causing them to have some premature labor. The integumentary system. So striae gravidarum, it's a very fancy term for stretch marks. So that lower bottom right picture, it looks like kind of pitting of the skin, or it can be like shiny lines. That is stretch marks. Not too fun to have, okay? Because unfortunately, babies leave you with that little souvenir for the pregnancy. It doesn't go away after the pregnancy ends. You can get them on the abdomen. You can get them on the breasts. You can get them on the thighs. You can get them in the buttock area, on the legs. And this is anywhere the skin has to stretch to accommodate that growing fetus, okay? Striae gravidarum. I know some people were telling me that there's some kind of laser treatments that they're doing now with the skin. There's so many different things out there that they're saying that helps to remove them. People also say, well, Ms. Herrera, can't you put cocoa butter to help prevent that, to make them go away? Actually, the cocoa butter is great. Like I tell the patients, get out the bath or the shower and lap that cocoa butter all over yourself, okay? Because it keeps the skin moist and it prevents it from getting really bad if it's going to occur. But it really doesn't. It's not like the miracle ointment that's going to take them away. But they're called stretch marks. And again, they like a little souvenir from your baby. The upper picture is called linea nigra. Linea nigra. And that is that black line. It's almost that straight line down right over the umbilical area. And what that is, it's related to hormones. It's very prevalent in dark-skinned women. African American women or even Hispanic women will experience this. The beauty of this, though, is that it does tend to fade, and eventually it goes away at the end of the pregnancy. Chloasma, that is like a blotchy discoloration of the skin over the face. We call it, a nickname for it is the mask of pregnancy. Okay, chloasma. It is related to hormones, just as most of the other stuff is related to hormones. One big thing with patients, we tell them stay out of direct sunlight because it can exacerbate it and make it even more prevalent. So it's called chloasma, mask of pregnancy. Vascular spider nevi, well, especially in the lower extremities, they tend to get some broken vessels and some little nevi present. That's from that extra weight that they're carrying around. Palmar erythema is again related to hormones. Over the palms of the hands, they tend to get this lacy looking, it's not a rash, it's just a discoloration, almost like little rings in their hand. Not everybody has this, okay, but this is just some things that patients can experience when they're pregnant. But it's called palmar erythema, and that fades again after pregnancy. It doesn't stick around, but it is a discoloration of the palms of the hands. Sweat and sebaceous glands are more active. As a matter of fact, they're more hyperactive with night sweats and can even give the patient some adult acne, okay, or acne. And that's because, again, those glands are hyperactive and there's a lot more night sweats. And you know what happens when there's sweating and bacteria and stuff like that. They can tend to get some clogged pores and even get some acne. So these are all things, again, related to hormone changes. Musculoskeletal system, the center of gravity will shift forward, and they'll complain of having backache because of lordosis. And again, if you got something weighing you down in front of your body, you're going to lean back to compensate and get that center of gravity balanced. So that's why they get lordotic and they complain a lot of backache. Okay. And then, of course, the bigger they get, the more, that weight is in the front. So that waddling gait is also something you might see. And what happens is they, at the end, especially when a baby drops down, they feel like it's a basketball in between the thighs. So they tend to waddle when they walk, again, just to kind of compensate for that extra weight in the front and kind of keep their balance. Diastasis recti abdominis, so those two beautiful muscles that are usually nice and tight, and they're those six-pack abs that you have. Those muscles are really tight and they're sewn close together. But unfortunately, when you become pregnant and that baby's growing and that uterus is growing, it separates those muscles and they move further and further apart, especially with every pregnancy. They never ever go back to that original state, unfortunately. I always tell patients, they're like, I've been doing sit-ups and I can't get my belly back in shape. It's just, I used to work out at the gym. I feel like I'm doing the same workouts, but I'm not seeing the results after this baby. Well, unfortunately, the only cure for that, or the only thing we can do, and it works, is to have a tummy tuck, okay? But I don't recommend you do that until you're done having babies, because like I said, with every pregnancy, it happens. And with every pregnancy, it gets further and further apart. So wait till you're done and then get your tummy tuck and then you get your girlish figure back, right? Those six-pack abs. But again, it's also related to hormones and the changes and that growing fetus and that big uterus. The influence of relaxin on joints. So relaxin is a hormone, and it can cause some changes with the patient's joints. Usually it causes some swelling. I know relaxin can have an effect when you're pregnant, and many people go through this. Their foot changes, their size of their shoe changes. I started off with a 5.5, and I have 2 children. So with every pregnancy, my foot grew a half. So I went from a 5.5 to a 6 with my first baby, and then a 6 to a 6.5 with the second. And I said, oh my God, I'm 5 feet, and I have very small feet and hands. Okay, I can't imagine having 10 babies and having a size 10 shoe or 12 shoe. Okay, but it does. I don't know if it ever stops growing, but I can tell you it does grow. It does change the shoe size, and that's related to relaxin, which is that hormone. Round ligament pain. Well, the uterus, again, is a big muscle, and there are ligaments that run through that muscle, that uterus. Usually there's ligaments on each side of the groin area, the bottom of that area of the pelvis. And those round ligaments off of that uterus, as that uterus grows, it tends to pull and kind of tug on those ligaments and can cause some discomfort. Almost feels like a bruised feeling. And I always thought my son, I just felt like he was breech for a little bit. And I always said, this kid is jumping with his feet on each side of my round ligaments. And it just felt bruised. But it's just the way it is. It grows and stretches and it can cause some discomfort. But not really bad, but it can be uncomfortable. Carpal tunnel syndrome, from all that increase in volume and all of that stuff going on, everything usually swells. Your fingers can, kind of feel swollen sometimes. Well, that carpal tunnel syndrome can come around, and it's usually something that can be exacerbated with pregnancy and not go away. I know patients that have never had it until they got pregnant, and then they had it until they had the surgery. Unfortunately, when you're pregnant, you can't have the surgery, but it may go away after pregnancy, but it's a lot of pressure on those ligaments and tendons and that area of the wrist. So carpal tunnel syndrome can occur. GI slows down. Just know everything slows down with pregnancy. So you get displacement of the stomach and the intestines by the uterus. Elevated levels of progesterone cause delayed emptying. Because of that, you'll have a decreased production of HCl and pepsin, a decrease in peristalsis, which of course leads to indigestion. Okay. Increase in saliva. Ptyalism is something that occurs. That's excessive salivation or excessive saliva in the mouth. And that's, again, because of that saliva production. Pica is something that comes about with pregnant women. That's a craving of some sort for something of non-nutritional value. And, like I said, I've had patients when I was in OB. We lived in the Midwest at one point with my husband's job. And the hospital was near a Indian reservation in the Midwest, and we used to have this little American Indian lady come in that was pregnant, and she had to be monitored close because she was high risk. So we put her on a monitor once or twice a week to come in for monitoring, and she come in with her little tin foil with her red clay from the reservation, and she would eat that. And I thought, oh my gosh, that is just not good, but it was her pica. And pica can be even ice. The hospital ice is considered pica. It's something that the patients crave and they eat, and it's not of nutritional value. But, what can you do? I mean, it is what it is. So it's called pica. Increased risk of gallstones. Because of everything slowing down, the emptying time of the gallbladder is prolonged, and the levels of cholesterol are increased. So it's not unlikely that you will have a patient have a cholecystectomy at some point in the pregnancy. I can remember many times that the recovery room would call the OB nurses up there to monitor the baby on their recovery room patients that had post-op cholecystectomies. So again, and everything slowing down increases the risk of those gallstones, and that's what happens. Morning sickness, there's some nausea and vomiting, especially during that first trimester from the increase in HCG levels. HCG is the human chorionic gonadotropin, or the pregnancy hormone. And as it increases, it gets worse and worse, especially in that first trimester is when the patient feels the most discomfort with nausea and vomiting. So that is also part of the GI system changing. Pyrosis from relaxation of the cardiac sphincter. So because everything slows down and you have that relaxation of that sphincter muscle, then the pyrosis or heartburn occurs. I don't know anything about the baby having more hair. I think that's just kind of a old wives' tale, but I can tell you patients do get indigestion and they can get heartburn because of that slow GI stuff going on. Constipation can occur, and of course it kind of goes hand in hand with hemorrhoids. So they get constipated, and then as a result of that, everything moving so slow, hemorrhoids can result, which is not a fun thing to have. But some people get them and some people don't. The endocrine system, estrogen will stimulate the uterine development and assist with ductal system of the breast. So that is that part, that hormone does that. Progesterone prevents early spontaneous abortion. Remember I said if the patient's progesterone levels are low, that the baby can be thrown off and she can have a miscarriage. So by giving progesterone, or if the mom has enough progesterone, it helps with that, and it also helps with breast and lactation. HCG is that pregnancy hormone. Relaxin inhibits uterine activity. It also softens the cervix, so that really plays a big part when it's time to go into labor. And of course, it relaxes those joints and makes those feet grow too. Oxytocin causes uterine contractions. We can make oxytocin synthetically that we usually use in infusions, but oxytocin here, what we're talking about, is the oxytocin that mom has her endocrine system naturally produces in her body. So oxytocin will cause uterine contractions. Nutritional aspects. So we want to make sure that mom is meeting her nutritional needs. Nutritional risk factors. There are risks involved, especially with different groups. So our teen pregnant moms, they usually don't eat very healthy. They eat a lot of junk food, a lot of soda, and of course, they don't take care of themselves. Sometimes by eating nutritiously, they eat a lot of like I said, chips and greasy foods and fast food and stuff. So they are at risk. Another risk group would be the homeless population. And believe me, when I was at Charity Hospital working as a nurse, right out of nursing school, we had a lady that came up in a wheelchair with just a sheet wrapped around her. She was, big and pregnant, and she was naked under the interstate, came in full blown labor. And, we do have population that are homeless. So of course they're not getting what they need. They're at risk nutritionally. So, that's our risk groups. They're at high risk. Lots of patient teaching. So we want to give them the information and the resources to help them so that they can get what they need to help their baby develop in utero, and they can get some nutritionally valued foods that they may not be able to afford in the store. I know WIC will provide them with different food, and even will continue to provide them after the delivery, and will also help with the baby's needs. WIC will provide not just formula, because I know a lot of people say, well, you call WIC and they give you formula, but for the baby, but they also now, because we are so, into the breastfeeding thing, they will provide the mom with a free of charge breast pump. So if they can't get the baby to latch on and they can pump the breast to get the milk, they cover the cost of that. So it's phenomenal. It's wonderful. So it's not just that we push in bottles in milk. We're also opening it up to giving them, and those breast pumps are costly if you run them per month, but WIC will provide them with a free breast pump. So lots of teaching. Prenatal vitamins with iron are a must. And as soon as you contemplate even thinking about getting pregnant is when you need to start those. And not just prenatal vitamins with iron, but the folic acid as well, because it does prevent neural tube defects. That's your spina bifida, your cleft lip, your cleft palate, all those things that are birth defects. It is scientifically been proven that folic acid does help in decreasing that occurrence. So physiologic discomforts and interventions, I'm not going to go over these, but the first trimester, and you can see all of them here, but I have a page or an addendum that I attached to the Canvas site, which goes over some interventions that we can do for all of these different ailments. Okay, so that's your first trimester, the second trimester, again, here's second and third trimester. And you can also refer to the chart on page 2253 and 2254. It's 33.2 is your diagram or your table that you can refer to. It also gives you information there. So these are all, again, ailments second and third trimester, but that page that I have attached to the Canvas site goes over every single one of these and the way that you can alleviate or help with interventions for these different ailments. Okay, mood changes, faintness, dizziness, dyspnea, altered body image, carpal tunnel, all that. Okay. One big thing we want to say, and this is just about at the end here. At the end of the day, the mom sometimes can complain of some swelling in the ankles and just feeling tired, and having some issues with their lower extremities. We can tell them if they want, they can put some pillows and elevate their legs at the end of the day. Sometimes that helps, especially with the leg pains, if they feel, that they're on their feet, especially with the jobs that they do. Another thing, try to help them with their posture, because that can also eliminate that backache. Of course, there's back rubs. If you get a nice person to volunteer to give you a back rub, a significant other, or looks like this lady's at some type of clinic or a Lamaze class or something like that, but somebody to rub her back. You can also stretch your calf muscle. Somebody can help you by flexing your foot up, If there's nobody to help you do that and you can't reach it because of that belly, you can always use the back of the chair to do some lunges to stretch those calf muscles and those ankles, to help with that. So those are just some other interventions that are, and just something that you can kind of go with. Um, and that concludes this lecture. Does anybody have any issues understanding any of this, especially like the TPAL or whatever? Please feel free to contact me via email. I am on campus a lot, except for when I'm in clinical. But just feel free to email me if you want to meet with me. We can set an appointment. You can come, and we can talk about what you don't understand. So, um, just my advice would be to follow the SLO and do all those readings, because of course there's so much going on here with these prenatal assessment and all the lectures for that matter, that we can't go over every single thing, but that's why we give you required readings, and of course the SLOs, your notes, and your readings, and anything else that we give you on Canvas. So feel free to contact me if you have any questions. Other than that, y'all have a great rest of your day, and I'll see you next time.